Good evening, everyone. On behalf of Eastern Melbourne Primary Health Network and Banksia Palliative Care, I wish to welcome everyone to the webinar When Community Palliative Care and the Role of the GP Meet. My name is Sonia Mbezi, and I'm the Palliative Care Program Facilitator at EMPHN. I've previously worked as a physiotherapist in palliative care for the last 12 years before taking on this role. Before we begin, I'd like to start with an acknowledgement of country. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nations whose unceded lands our work in the community takes place. We pay our respects to Aboriginals and Torres Strait Islander cultures and to elders past and present. EMPHN is committed to the healing of country, working towards equity in health outcomes and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters and practitioners who work with them and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. So just some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box at the bottom of the screen, and these will be answered at the end of the presentation. Just a little bit about the PHNs. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. The PHNs achieve this goal by improving access to existing services, commissioning services to improve health outcomes, and by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. Community palliative care serves as a vital element in improving the quality of life for individuals dealing with serious illness and their families. It provides the necessary compassionate support and specialised medical care to manage pain, symptoms, and emotional distress outside the confines of a hospital. In this context, GPs play a pivotal role as the main point of contact, delivering consistent care and personalised assistance. GPs work in collaboration with the palliative care team to address the physical, emotional, and spiritual needs of patients, ensuring they can make the most of their valuable time in familiar surroundings while receiving comprehensive and holistic support. Now, to introduce our wonderful presenters for the evening. Dr. Chien-Che serves as a palliative medicine specialist consultant across various hospitals and community palliative care services in Victoria, including Banksia Palliative Care Service. Additionally, he practices as a general practitioner on Saturdays. His unwavering dedication lies in supporting individuals with progressive, incurable diseases to enhance their quality of life amidst the challenges of illness and end-of-life care. Chen's commitment extends beyond clinical duties. He tirelessly works to enhance community care through both his clinical and administrative roles. Moreover, he actively engages in teaching and mentoring medical students and specialist trainees, fostering a culture of academic excellence and compassionate care across all clinical environments. Wendy is a registered nurse with over 30 years' experience, with a significant amount of that time being spent as a community palliative care nurse. She's currently the training and development consultant at Banksia, responsible for internal and community education. Wendy is passionate and compassionate about best possible palliative care outcomes for people living with a life-limiting condition. And finally, Dr. Bonnie Liu, as a palliative care physician and geriatrician with experience working in various hospitals and community settings. She currently works with Banksia Palliative Care Service and the Austin Hospital. She has an interest in community-based healthcare and endeavours to support patients in their transitions through different healthcare settings and illness trajectories. Bonnie is also involved in teaching and supervision of medical students and doctors in training. Thank you very much, and I will now hand over to Chien to commence the presentation.
Can you see my slides?
Certainly can, Chien.
So yes, our first topic of this series is when community palliative care and the role of GP meet. So first of all, some acknowledgements. So at Banksia Palliative Care Service, especially Dr. Scott Reeves, who is also responsible for creating a lot of the content and is the usual speaker, one of the usual speakers of this talk, and unfortunately he can't be with us today. And so we're standing in. Michelle and Annie, Michelle's the CEO, and Annie's one of our engagement officers, and again, can't have the sessions without them. Some others that have contributed to the content of the slides are included our colleagues at Eastern Palliative Care, and of course, Sonia and Meg both online today, and from Eastern Melbourne Primary Health Network, as well as Northwestern Primary Health Network, Jen, to make this happen. So we'll start with an overview of tonight's session. So we'll talk about so who is Banksia, what is palliative care and how it is delivered, the role of community palliative care, what supports community palliative care provides, a case study, and interventions, medications, practical supports, bereavement support, and definitely the verification and certification of cause of death in the community. So first of all, who is our Banksia? Banksia Palliative Care Service is the only not-for-profit community palliative care service in the northeast suburbs of Melbourne. So the three local government areas are Banyong, Nillumbik, and Whittlesea. It covers about 1,000 kilometers squared of area, and I think last year's data was 420,000 population. So it is a home visiting palliative care service which provides care and support to clients and their family 24/7. So that includes planned visits during the weekdays, but also unplanned call-outs, unplanned visits, triggered via 24/7 triaging on-call process in settings where people are wanting to remain home for end-of-life care and have things they need to troubleshoot and help. The Banksia team work alongside with other local healthcare services and providers, and especially the general practitioners who are our main medical providers in the community, and other medical specialties as if you're still involved as well. So, of course, we work closely with the aged care facilities, local councils, Bolton Clark, to share all the tasks, day-to-day routines that the person might need at the end of life care. Quick snapshot. This is hot off the press. So one of our admin kindly put this together today. So our referral received in 2023 was 1,279, so 22% increase from 2022. 8% were, and Banksia, like many other community palliative care services, is a service where everyone can refer. Of course, we will need to chase medical informations in this process of intake. But yes, 8% are actually self or relative referred. And otherwise, as you can see, GPs and other health specialists, private specialists, make up 38% of the referrals, and another 38% from the hospitals and inpatient acute and palliative care services. Aged care facilities account for 16%, but of course, that's from the facility staff itself. It may be the GPs or other health specialists referring, but the person actually lives in aged care. Admissions completed for 1,086 patients in that period. So, and that is because people may have ambitions to come home but never do, or may have died prior to being able to be assessed, and hence we are always trying to get everyone to refer as early as possible, or timely, really, because at the moment there's still a lot of late referrals. Non-malignant now makes up 46% of the admissions and 54% of malignant. So that's used to be overwhelmingly cancer diagnosis that gets people referred to palliative care. But as you can see, it's roughly half and half nowadays. In terms of the deaths, so 138 died on the program during that 2023. So 40% is hospital inpatient and 60% is at home, including residential aged care facilities. So what is palliative care? Palliative care is a person and family-centered care provided for a person with active, progressive, advanced disease who has little or no prospect of cure and expected to die, and for whom the primary treatment goal is to optimize their quality of life. So this is from Palliative Care Australia website. Key points is life-limiting illness, expected to die. Now, the 6 to 12 months thing kind of also relates to funding, and that, of course, all of us are dying at different rates. But yeah, we do need to work out who needs the service the most, and after 6 months or 12 months, that's a common reference point. And that's generally the last 12 months of life. It's often, we know people really may need extra support and have a change in focus in their life. So potentially, we nowadays we get involved in curative. When we say curative, the disease may be controllable, but there's still a high risk that it's not. Transplant patients comes to mind that they may be dying until the organ comes up and they receive it, and they may actually recover. So on the other hand, the care needs are real and symptom needs are real, and they need support, and certainly they need a plan if they're not well enough to receive organs. So it's a very different approach, but nevertheless, key is that risk of dying and that focus is quality of life. The key is it's not equal to no care. So patients can receive palliative care together with other therapies that are intended to prolong life. And again, in fact, if you can't fix the problem, chances are they need more care. There's more to do. So rather than there's nothing to, there may be no treatments to do, but most of the time people have a lot more care needs if you actually can't cure the disease altogether. It aims to enhance quality of life and help people live as actively as possible. So it's really living as well as possible with dying. It's not about the dying totally itself, but it's more about how to live as well as possible with dying. Regards dying as a normal process, provides relief from pain and other symptoms, intends neither to hasten nor postpone death, integrates the psychological and spiritual aspects of care, uses a team approach to address the needs of patients and their families, and offer a support system to help the family cope during the patient's care and in bereavement. So who benefits from palliative? So anyone, so adult and children. We certainly do have pediatric patients on the program, and we work very closely with the Royal Children's and Monash Children's, the pediatric palliative care team to look after them. And traditionally cancer, perhaps the most clear-cut diagnosis for a long time and predictive of progressive increasing care needs and symptom needs. And we know degenerative neurological diseases, things like motor neuron, but also nowadays we know end-stage organ diseases can carry with them similar amount of care and symptom burden, and dementia and inherited metabolic disorders. So anything that's life-limiting or life-threatening. Who provides it? So there is some sort of delineation of generalist and specialist palliative care out there, but really it comes down to whether you do this every day, this is all you do. I think if we're specialist palliative care services, because this is all we do, whereas it is everyone's business, and GPs, oncologists, geriatricians, and really everyone, if their patients are dying, they need to be a part of the palliative care process. Typically, if we're going to label ourselves specialist services, we do try to have multiple disciplines involved with specialized skills, competencies, experience, and training for people with more complex needs. And but it's slightly different from other specialties in that it's not like surgery where only the surgeon does the surgery, whereas this is very much a shared care process where we're not here to take over care, but we're here to share and support the care that's been delivered already. And it's not here to disrupt that relationship, because we know that the relationship is therapeutic. It can be provided at home, at a specialist palliative care unit in the hospital, in the aged care facility, or anywhere the person identifies as being their home. So now to focus on the community. Uh, so overwhelmingly, uh, when you ask people where they want to be at the end of life, people say they want to be at home. And I mean, it's true that not death literacy is not that great. So whether people know what that actually means is hard to say. But there is no place like home, and from previous studies, we know it's pretty. Australian reports are fairly similar to worldwide reports, and about 70% of people would like to be at home if possible. But really, in most cases, it doesn't occur at home. And there are a lot of practical barriers to that, as well as preference barriers to that, because of course, dying is not just one person. People need the care, and generally, people can't look after themselves in these type of situations. So it is dependent on their carers, their families, but also the health services around them and what's available. And the key is we want to make sure it's as feasible an option as possible. So, and by providing as good a service as possible, then hopefully we can at least increase the confidence, if not the actual number of people to stay home when they do want to remain home. So hopefully by attending today and our upcoming seminars together with us, you can help us improve this number and also the overall quality of life and care in our shared patients. So very quickly talking through what supports Banksia provide. So we are a specialized team of health professionals, healthcare nurses mainly, and social workers, and we have one physiotherapist and one allied health assistant overseeing the equipment, but also other sort of exercise / energy conservation / other non-pharmacological techniques of management, art and massage therapist, and client support volunteers. And we do have palliative care physicians and specialists, and that's myself and Bonnie on today. And but we're here to support the person's general practitioners. And the general practitioners are respected and expected to remain the medical care providers for people living and dying in the community in Victoria. So we're not here to take over care, but to support everyone to deliver care. So as we mentioned briefly before, it is access to support 24/7. So it's a 24/7 phone triage service, which can trigger advice around how to manage new symptom or care issues, implement previously prepared plans, and potentially unplanned call-outs. And this is to all environments, as long as it's a safe environment that's been assessed, including nursing homes, that its unplanned visits are available 24/7 in case they need additional face-to-face assessment and support. We do coordinate equipments to aid care at home, the social work input for sensitive complex issues. And again, our social work are from a variety of backgrounds, and there are counseling work, there are care coordination work, there are many other more specialized work as well, depending on the needs. Allied health input, we still have music therapy up here, but we now have an art therapist and massage therapy, and respite and support. By respite, it is for the carer daytime that we have a support team who can come out for to arrange that to come out for a few hours and give the carer a bit of a rest. And in the community, we can arrange direct admissions to palliative care unit. This reduces stress to the person and the carer, also assists in reducing the burden to the healthcare system by avoiding the need to present to ED. So generally, if there's no new diagnosis to be made, there's no reason to investigate further because we know there's no treatments available or the person is flat out refusing treatments. But on the other hand, are not able to care for at home, then direct admission is available through Banksia. And it's better to wait at home than wait in ED for a bed. So I'll hand over to Wendy to run our case study through.
Thank you, Jen. We thought the best way to illustrate how Banksia can support palliative care in the home in collaboration with the client's GP. It's not an overly complicated scenario, but a very common scenario. So we have a case study, Mark, who's referred to us at 3 p.m. on a Wednesday by his aged care case manager, and it's marked as urgent. There is no medical information provided. The intake nurse makes a phone call to the home and we ask a few questions, and we get an idea of how things are for Mark. So he has been increasing trouble getting out of bed. He's only eating and drinking small amounts. Pain, shortness of breath, functional decline, and multiple admissions to the hospital. Mark wants to remain at home for end-of-life care. And the medical information, there was a medical information request sent to the GP clinic and the local hospital, because sometimes we often do have to follow that up. So from that medical information that we received, we determined that Mark has end-stage COPD, apologies. He had past medical history of chronic back pain from a motor vehicle accident about 15 years ago. He has asthma, hyperlipidemia, a left total knee replacement, and chronic renal failure, with his most recent bloods shown creatinine 166 2 weeks ago. He's had 3 admissions to hospital in the last 6 months with chest infections and exacerbation of COPD. With the most recent 2 weeks prior, and no discharge summary yet available. So we would have to follow that up as well. His wife, Sarah, is very stressed and wanting to keep Mark at home. They have 2 adult children and 4 grandchildren, but they are busy, they're supportive, but they're not able to help as much. Oh, thanks, Chien. So Banksia admitting nurse were able to visit Mark Thursday the next day because it was marked as urgent. We call that a Category A admission. He's sitting in his recliner with shortness of breath and a moist cough. Minimal oral intake in the last 24 hours, mostly fluids, but still able to take tablets. But that is also becoming more difficult. He has increasing back pain and is using oxycodone 5 milligrams 4 times a day, in addition to Taj and BD. Sarah is struggling to transfer Mark to the toilet and to get him out of bed. Mark is aware that he is deteriorating and wanting to remain at home and not return to hospital. There's no other GI symptoms, GIT symptoms. Mark last saw his GP about 4 months ago, as he was unable to get to the clinic, and his GP works Monday to Wednesday. So he did have a telehealth appointment 3 weeks prior to the recent hospital admission, and is currently receiving a level 2 package for providing hygiene 3 times a week, 2 hours of respite every 2 weeks. So we find with his medical information, we find that Mark has expressed an allergy to morphine, severe nausea and vomiting. However, many people do state they have an allergy to morphine, which is often more a side effect and can often be prevented with the antiemetics generally. But having said that, we do avoid commencing morphine just in case. He has been on Tarjan for approximately 6 months and using oxycodone regularly every day. So there's the Tarjan 10 BD. His prednisolone had been weaning down from 50 since discharge from hospital 2 weeks ago, so it's now 10 milligrams. So there are many things to consider when a person wants to die at home. GP engagement is one of our first and foremost follow-ups. Also for not only for medication scripts, but for the provision of a death certificate. Equipment needs, gaining equipment needs in the home, like hospital bed or bedside commodes. Access to end-of-life comfort care medications to manage the symptoms, regular nursing visits, access to after-hours support, practical and emotional support for Sarah and the family, and bereavement support for them as well. So on that day of assessment, Mark is clearly deteriorating and entering his terminal phase, and he does want to die at home. The nurse who's visiting is in contact with the GP clinic and just trying to provide support to the GP as well as information as Mark is deteriorating. Given that swallowing tablets has become more difficult, there is a discussion about rotating to a fentanyl patch with liquid breakthroughs, and a discussion using hydromorphone rather than morphine, and also due to the renal, possible renal issues. Safer Care Vic website has a lot of information regarding anticipatory medications, care for the dying, opioid conversions, palliative sedation therapy, and syringe driver compatibilities. They're a great resource that we often use. So here is just an example of one of the doctor's letters that we would send to the GP. We would advise that Mark has been admitted to our service, and that we make suggestions or advise what we find and what suggestions that we would have. We would also do follow up with a phone call and advise that there is a deterioration of care. I think the next slide shows us an example of sample syringe driver orders and breakthrough medication orders. Although this does show for morphine for the breakthrough medication orders, down there in the red, you can see that if there is known renal impairment or an allergy, then hydromorphone is recommended or preferred. So we do actually send that along with orders, but we can also support this on the telephone. And on the next slide, this is our syringe driver and breakthrough medication order that we would send to the GP with request to be completed and sent back to Banksia so we can attend to those medications. Not only that, the scripts would also have to be requested, and sometimes we need to follow up the appropriate pharmacist to gain those medications. Not all pharmacies will stock everything. Sometimes it's a bit of a wait, like order overnight, or if in the weekend there might be some follow-up with that, gaining those medications. So those common medications used at the end of life are just play an integral part in managing symptoms for the end of life diseases and optimising comfort and ensuring best possible quality of life. Injectable medications may be required when the person can no longer tolerate oral medications, which in Mark's case, it's starting to happen. So we try to have medications in the home before it actually does happen. That's why it's anticipatory. We try to predict, we can't also predict always, but we anticipate there will be deterioration and they won't be able to take those oral medications. So those medications for pain, for example, would be your morphine and hydromorphone and fentanyl, for example. Nausea, metoclopramide, haloperidol or cyclizine. For agitation, the clonazepam, midazolam and haloperidol. And for the secretions or the noisy breathing, the glycopyrrolate, atropine, hyoscine, butabromide. The Banksia's follow-up on the day of assessment. Education is provided to the carers regarding medication changes and action plans. Verbal and written information is provided. Lots and lots of support. Lots of gentle encouragement, because it can be quite scary for family and carers when they're looking at injectables. We provide practical information regarding slide sheets, pressure area care and mouth care, and also carer needs. We can assess the bereavement risk. The stress levels of the carer can indicate how much of a bereavement risk they will be, and the any urgent equipment that might be required, along with a referral to Carer Gateway. Along with that, we have a handover to the team, Banksia Palliative Care team, and an updated fax to the GP clinic. The regular nursing visits from a Monday, Wednesday, Friday, and ongoing social work support. So after hours page triage, there was a page on the Sunday evening from the family to say that there's deterioration of swallowing, worsening chest secretions and restlessness. So then the nurses have commenced with that hydromorphone breakthrough orders of 0.5 to 1 milligram subcut, the buscopan and the clonazepam drops. So Mark is now entering into his terminal phase. Contact with his regular GP on Monday morning to update and discuss Mark's admission to Banksia and the changes that had happened over the weekend. The ongoing issues with the shortness of breath, secretions and restlessness, and due to Mark's use of breakthrough medications, over the weekend, a syringe driver that was commenced on the Tuesday with hydromorphone 3 milligrams, buscopan 80, midazolam 10 over the 24 hours. So at this point, Mark has got daily nursing visits. We have a carer support program where our enrolled nurses will also come and provide assistance and education for personal care, personal hygiene. So it is actually routine practice for our nurses to make contact with the GPs when the client enters the terminal phase, to ensure that you're aware that things are changing and that there are no surprises in a few days, and that also that we like the injectable medications to be scripted and ordered for the client. So Mark died the Friday comfortably at 11 p.m. The nurse visited to provide verification, and notification of death is faxed to the GP the next day, and we often actually make a phone call to follow that up. The verification is usually done as according to the family wishes, and it depends on how soon the family would like Mark to be collected by the funeral directors. So the take-home message is really that it really illustrates the importance of GP support and engagement to ensure that smooth, I call it a calm transition into heading towards end of life. Banksia don't have a nurse practitioner, therefore our GPs are our first port of call in the way of providing scripts and support for our client. It is very helpful for GP clinics to have GPs who can provide interim cover when their regular GP is not available or on leave. So, and although our palliative care doctors are available to provide support when nurses are unable to get in contact with the GPs for complex symptom management, the GP remains the medical service provider for our clients, like Chien mentioned before. Prompt access to injectable medications is also very important. Provision of equipment, whether that be whatever that may be for the family. Sometimes people don't like hospital beds, but we try to get, definitely encourage as much equipment in the home, really to support the carers. Increased carer support, regular nursing support, ongoing social work support for the family, and also the verification of death and the provision of the death certificate. So they're all important requirements to ensure that people are having end of life at their place that they wish to be. So on reflecting Mark's situation, he is what we would call a late referral. So ideally, a more timely, a bit earlier referral is best for just to reduce those stress levels for the family. Of course, sometimes it's not always predictable, but earlier is better. Many patients are with us for many months and years. Actually, we've had clients that have been with us for over 2 years. And if they do remain stable for a long time, we do end up discharging clients and then readmit them again if they're deteriorating. So this can happen. Over to you, Chien.
Thank you. I can't remember which part we I take over. Yeah, so thank you, Wendy, for taking us through that very common scenario. And absolutely, we are heavily dependent and we work closely together with the general practitioners. So common interventions, medications, and practical supports that, as we've already touched on. So while they're only programmed, it will have regular visits from experienced registered nurses to assess symptoms, trajectory of the disease for the patient. And there are unplanned emergency provisional equipment to assist care in context of functional deterioration in a life care scenario. Banksia actually will fund 6 weeks of this provision, but essentially contact your local community palliative care if you're not in our catchment. Support from social workers and grief counsellors to provide emotional and social support for patients and their carers. and anti-health input, such as music therapy, art therapy, and massage therapy. So medications. So this registered nurses, senior nurses will provide advice around symptom management medications, and general practitioners remain the main treating doctor. We will often ask for what we call anticipatory medicines, and in that they're used by our nurses. Then the patients and their carers are not expected to use them by themselves. They call, but if the medication is in the house, that's where we can guide them plus attend to get them started using medications if they're not able to tolerate oral alternatives. Again, if the course of care is for comfort measures and setting of deterioration, and really we know there's no further treatments to pursue, or there's no a preference not to pursue further treatments, and having the medications in the home really it prevents unnecessary hospitalization and suffering if there's pain or agitation or nausea or breathlessness or respiratory secretions at the end of life. And we are available for additional special support. And we're here again not to take over care, but to work with the person's GPs. So the 24/7 phone number for with the visiting service to provide specialist advice, and this is available to the family. And, but also any other care providers, if you're attending the family, they can call the number. And we quite commonly have calls from ambulance and or virtual EDs just to check in. When was what happened previously, and also to hand over ongoing care. ENs provide, so we have enrolled nurses as well to provide training and family for providing personal care, and they do help with, like we mentioned, respite cases to help hand out personal care for a few hours at a time, especially someone who's in the terminal phase or essentially imminently dying. And registered nurses provide counseling to family about what to expect at the time of death, attend home to verify death. Big ones are respiratory changes end of life. So if someone's unconscious, of course, we use the analogy of snoring, people breathing get louder, just to reassure the family, because of course everything's distressing to the family. And we talk about other common changes, non-distressing changes end of life. So moving on to another big objective of today is the medical certification of cause of death. And this is really for legal purpose more than physiological purpose. It is for statistical public health purpose, for family members, or for safeguard purpose. So really it's to prevent disposal bodies without professional scrutiny, basically. But also has a lot of public health and family sort of future planning type of benefits. And it's different from verification of death, which is the examination of signs of life, because there's no signs of death, there's the absence of signs of life. And our nurses, and in fact ambulance officers, can actually do verification of death, but it is the treating doctor who provides the certification of cause of death. And so the person's nominated GPs will approach first, and a doctor who's responsible for the person's medical care immediately before death, or who examines the body of a deceased person after death, must, within 48 hours after death, to notify the registrar of the death. Now, this is not strictly enforced, so there's often quite practical delays, and there are some family preferences and requirements where this needs to be done so the funeral can proceed, especially notable some religious preferences and requirements. But outside of that, it's not a strictly enforced one, but highly recommended to get it done within 48 hours. The cause of death is the disease or injuries which initiated a train of morbid events leading directly to death, or the circumstances of the accident or violence which produced the fatal injury. Of course, if it's an injury, it's we need to complete a deposition form to report to the coroners. So we're talking the disease in this case. which is why often if someone died of cancer, even though yes, there are many other complications, you can actually just put the cancer down in Australia. Completion of medical certification of cause of death. So again, because when someone's living and dying at home, their main doctors are GPs, so the GP clinic will be approached first. Some cases, if there's no one available to help, then sometimes the discharging hospital may feel eligible and available to provide this. In some cases, so again, if we have seen the person, one of the Banksia physician will try to help with this, but we certainly don't see at any one time. So at the moment we have 475 patients on the program, so we certainly don't haven't met all of them. So definitely work with the person's GP. It is passed on to the Office of Coroner, which essentially staffed by the same people as birth and marriages, from what I can gather. But yeah, it's but if there's any questions, just ring and talk through. In terms of brief, actually, I might just quickly touch base, because a common question about eligibility is because when you complete the death certificate, it will ask you, oh, when did you last see the person? So there's actually no legal requirement for recency of seeing the person. And in fact, phone consultations actually satisfy the requirement nowadays, since COVID and since telephone Medicare supported. So and the other thing is, if you're covering for another GP in a clinic, you can complete it, but the last time that the person is seeing, we can put the date of the covering GP who's or the main GP perhaps who's seen the person. So in terms of grief and bereavement, so we have counselling for individuals and families, information and education on grief, loss and bereavement. We have remembrance services and walking groups, and we do also refer to Australian Centre of Grief and Bereavement for ongoing, but we have, I think, 13 months actually of follow-up available to all our patients. Referral. So this is the big one. So anyone can refer themselves, as we mentioned earlier, but we certainly need the collaborating service providers, especially GPs, input and informations. The referral can come from telephone, so just call us, visit our website, follow the link to make an electronic referral. If you're outside of Banksia's catchment, to find your local service, you can go onto Healthcare Victoria and enter the postcode of the person's address, not your clinic address, but the person's residential address or the residential facilities address, and put it in, and we'll tell you which service providers they are. Just very quickly to touch on other services around that we all work together with. So there's a statewide palliative care advisory service, and this is quite useful if this is someone who's not on the program as yet, and you can't reach us, or potentially was not appropriate for palliative care, but there's a sudden change, and again, if they don't have enough, they can call, or you can call. As usual, a health professional calling is always more useful. There are hospital-based palliative care services, which are generally short-term or transitional, other than outpatient clinics, which again, people may or may not be able to attend. So we all work closely with the community healthcare services as well. So there's inpatient PCU, inpatient consult, outpatient clinic, and there are outreach programs like Rapid, and there are rarely hospital and home programs where they actually do take over care for a week or less. That's not in our catchment, and certainly not commonly available across the board. But some hospitals do run that. Again, find your local service, just search on Healthcare Victoria. Want to quickly touch on the current research trials and our resources. For those of you who listen to ABC like I do, there's a lot of cancer trials being highlighted as important legacies, important opportunities for people to potentially have a better lifestyle or have better quality of life and symptom management, because again, we are always looking for new things. And so the four that's notably run in the community. We have a comment program, and residence is run out of Austin, which is why I've listed the direct contact in the slides. But there's also Depart, Namisol, and Symphonia, so Singing for Breathlessness, the cannabis trials, and the Diloxin and pregabalin trial for cancer pain. I will now hand over to Crystal for HealthPathways.
Thank you so much. Sorry, it's just taking a little while to share. Sonia, did you just want to let me share?
Yeah, I've just edited it now. I think it was because you
Thank
left and came back in. So let me know if
My
that's...
apologies.
No, that's okay. Is it working now?
We shall soon find
Perfect.
out. There
Yeah,
we
I think
go.
excellent.
Okay. Thank you very much for that. Yes, so hi everyone. My name's Crystal Pedrobedo. I'm the program specialist at HealthPathways Melbourne. I understand it's the end of the night and time is precious, and we've all got other things to do this evening. So I'll make it quick as I can. Just wanted to demonstrate how HealthPathways Melbourne can be a fantastic resource to ensure you can swiftly access the right and relevant information at the point of care with your patients. It's designed it's a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. It provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other providers in delivering consistent and evidence-based care to their patients. In today's presentation, I'll demonstrate how to access and navigate health pathways and find relevant pathways on palliative care and the role for the GP. Okay. So navigating health pathways, you simply log on to our website. Here, this is our landing page. You can see the latest news section and the pathway updates. You can search for the relevant page by using the search bar at the top, and here I've added in palliative care. Or you can use the table of contents down the left-hand side. You can choose the page that is relevant for you. We've actually got over 40 pages in our palliative care suite. Today, we're going to look at the new palliative care patient. Here you can see we also have links to other pages. Firstly, we've got a clinical editor's note, which is specific to the PCAM and access to the core medicines. Just quite useful. As we navigate further down the page, we come to the assessment section, which provides a concise list of steps that users may consider taking. Throughout, there are drop boxes that provide additional information, such here as risk factors shown with physical and psychosocial concerns. Going down to the management section, a succinct list of steps that users may consider taking. It includes additional information shown here with this drop box of at risk of dying and highlighting other places you can go as well, such as our advanced care planning. Clicking on that will take us over to our advanced care planning page, which will provide you, again, with all the paperwork that you will be required, all the resources and links going out with relevant phone numbers. Returning back to the page here, as we continue to go further down the page, we'll get to the referral section. And here we've got a referral for the specialist palliative care services. Clicking on that will take us out to our relevant pathway. And on this page, you'll find a list of private and public. It will provide criteria and links out. Example here with community palliative care. We have a list of criteria. Further down, we've got refer to the service. We pop under Eastern Melbourne. We can see Banksia Palliative Care right there with all the referral options. Returning back to our page, at the very bottom of the page, you have an information section which provides additional information and links for health professionals and for patients. There are over 40 palliative care pathways. Here I've listed quite a few of them. Most of them here in the palliative care section will be quite supportive for GPs as well. And further on, I told you there's quite a few. These have all recently been updated as well. HealthPathways Melbourne is available to general practice teams and other clinicians in the Eastern Melbourne and Northwestern Melbourne PHN catchments. To access HealthPathways, you can follow that QR code or you can send us an email at info@healthpathwaysmelbourne.org.au. Thank you so much for your time, and I'm going to hand over to Sonia.
Thank you very much. Now we've got just a couple of minutes up our sleeve, and I was just going to check with our other presenters if there was any questions they wanted to speak to before I wrapped up. No, everyone feels like.
I might just quickly touch on, because we know there's a few comments about being part-time and we're all very busy, and absolutely the workload's escalating. It's really just identifying there's no other specialties that can take over the GP's role in the care team, and we all work together, and that's why it's specific. We want to say it's consultative or shared care, but we do share and do where we can, but we absolutely need the GP on the team to provide all the best possible care for a person living and dying at home. So again, feel free to give us a ring or email if there's any questions or worries. And a lot of things are quite straightforward. And we know from beach data, about 2 out of 1,000 consultation is palliative care related. And of course, people may not have had a patient who needs palliative care input for a little while every time. So which is why we run these refresher sessions a few times a year. And we'll have, hopefully this year as well, updated recordings available from the Primary Health Network website. And again, it's, if you need a refresher, if you need a question on the spot, just ring. The patient, if they're on the Banksia program, they'll have a 24/7 number that's for you as well. So just ask for it from the patients. Give us a ring. We can work out with you what to do.
And just to add to that, Chien, with Banksia, we do have like a palliative care physician available at least half a day, Monday to Friday. And we're very happy to speak to GPs directly. I think, as you mentioned, Chien, GPs play such an important role in supporting patients as well as their families in the community. And if you haven't had much involvement in the past, especially in this period of time, especially once they've been involved with Banksia, we do encourage patients and their families to re-establish that therapeutic relationship as well on a regular basis.
Beautiful. Thank you both. All right. So thank you to everyone for being part of tonight's session. It has been a pleasure to have you here and host you. I hope you've taken away some valuable insights about palliative care, and I'd like to extend a special thank you to our presenters. By participating in tonight's RACGP accredited activity, you will receive 1 hour in educational activities, which I will lodge on your behalf. So that we can further improve these education workshops, please take a moment to fill in the events survey, which you can do by scanning the QR code on the left of screen. At the end of this session, the survey link will also pop up. Your responses are greatly appreciated and highly valued in creating these targeted education sessions. If you haven't already done so, please register for the next of the series, which is Delirium and the Use of Sedatives in Community Palliative Care, which is held next Wednesday at the same time, 7 p.m. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you've seen tonight, in addition to any other relevant resources. You will also receive your certificates via email within the next 4 weeks from Eastern Melbourne Primary Health Network. Thank you for all of your time tonight and attention, and we hope you have a lovely evening. Bye for now.